I enjoyed my time in Chandigarh. So traumatic brain injury clearly is a very common disorder. I mean, these are data from Europe and the US. It shows you the incidence. In fact, this is more common than combining breast cancer, multiple sclerosis, and many other conditions that receive a lot of media attention. But the majority of these cases are going to be mild, but about 10 to 15% are moderate to severe. And the commonest cause of particularly significant brain trauma is road traffic accidents, followed by things like assault and other things, but by far RTA is the commonest cause of this condition. Now, the way I'm going to go about this talk, this is going to be a clinical talk, really. I'm going to present a case history, talk about the frequency of pituitary dysfunction after TBI, the natural history of post-traumatic hypopituitarism, the clinical implications, and some guidelines about screening and management. So this is a patient that we saw some time ago. In fact, he was a man who had a seizure following alcohol intoxication, had severe traumatic brain injury, was in the hospital for 3 months, spent several weeks in intensive care. And it was noted a few days after his admission that he was hyponatremic, and this was attributed to SIADH. He was fluid restricted, but the sodium remained low. And then after several weeks, endocrinology were asked to see this man. And just show you his CT scan. This is his admission CT scan, and you can see blood everywhere here. I can use the arrow, but you might be able to see that in the pituitary fossa area, there is some blood as well. And in fact, this was missed, and the patient was treated as your classic head injury, fluid restricted, and he remained very unwell for several weeks. We were asked to see the man. We thought about a different diagnosis here for his hyponatremia, and we checked his cortisol, and this was low, and we proceeded this about 2 months later to do a glucagon test. So the glucagon test, we have a lot of experience with the glucagon test. It's a good test for both growth hormone and cortisol secretion, more for growth hormone. But you can see here the cortisol values. His AM cortisol is quite low, and he does not achieve adequate response to glucagon. You would expect a response of over 450 nanomole per liter, which is around 16 microgram per deciliter if you're using mass units. However, his growth hormone response is normal. And we checked other hormones. We checked his ACTH, that was low. His testosterone was low normal. You have to remember this man was sick, so that's not unexpected. Lowish LH, but his thyroid function and prolactin were normal. So he was treated with hydrocortisone. His sodium recovered quickly, and this is what you'd expect in cortisol deficiency. The sodium recovers usually within a day or so. And he felt much better. He was discharged for rehabilitation. And then we brought him back for reassessment after, don't know if you can see the top of the screen, but this was after 12 months from his injury. So 10 months after the last test, we repeated the glucagon test, and this time he had a normal cortisol response. So his cortisol secretion, ACTH cortisol secretion has recovered. His growth hormone now is blunted with a peak of 2.2. Testosterone is normal. His IGF-1 is in the normal range. And we decided to do another test to confirm that he continued to have normal cortisol, he has normal cortisol production. And that's the corticotrophin test. It's a simple test to do. And that was done subsequently and confirmed that this gentleman has recovered his cortisol production. It's a completely normal response, a response of over 450, we take it as normal. But now with the arginine test, which is another test for growth hormone secretion, we couldn't do the ITT clearly because this gentleman had seizures. So the alternative was the glucagon and the arginine, and this arginine now showed undetectable cortisol despite stimulation, and his IGF-1 has dropped. So this case really illustrates very nicely the natural history of this condition. He had acute post-traumatic ACTH deficiency and partial gonadotrophin deficiency. And at 12 months, there was a recovery of his ACTH cortisol secretions, and also his testosterone recovered, but he developed late onset growth hormone deficiency. So what do we know about the frequency of pituitary dysfunction after TBI? So a few years ago, we did this study. This is a study in survivors of TBI. So they were at least 6 months following head trauma. All of them had severe or moderate TBI as judged by the Glasgow Coma scale scores. And those patients had really 2 stimulation tests. So they had a screening test, and if they failed the screening test, they had a second test to confirm the abnormalities. And based on these two diagnostic tests, we had 9% of those have severe growth hormone deficiency. This is an indication for a treatment. 13% had ACTH deficiency, 12% gonadotrophin deficiency, and 12% had high prolactin. Only 1 out of 100, this was 102 patients, only 1 had TSH deficiency. And in this study, we found no correlation between the pituitary dysfunction and the severity of TBI, in other words, the Glasgow Coma scale score. But you have to remember that all these patients had significant head trauma, and the reliability of the Glasgow Coma scale score it clearly is limited in a situation where it's done by somebody else, and by the time the patient arrives at the hospital, often they are already intubated and ventilated. And since the original studies in the early parts of the century, there have been many studies, and I'm just showing of these studies. This is not by no means every study. There has been more, but it's just a representative sample. And you can see in this representative sample, if you go to the end row here, over 1,000 patients, 9% growth hormone deficiency, about between 6 and 10% deficiency in the other axis. And overall, about a quarter of them had hypopituitarism. And in fact, the majority of those with hypopituitarism had single hormone deficiencies, although a small percentage had multiple pituitary hormone deficiencies. And this is a meta-analysis that we did some time ago, and this showed the frequency of TBI in a meta-analysis. Approximately in this study, about 30% of patients, about 29% had hypopituitarism. The commonest deficiency was growth hormone and gonadotrophin deficiencies. So in fact, there have been so many studies in this area that the evidence now is very clear that these patients, particularly with severe or moderate TBI, are at increased risk of hypopituitarism. So how early can you detect hypopituitarism in those patients, and what happens over time? So we studied 50 patients in the early stage after TBI. Again, all these patients had severe or moderate TBI. So we studied them approximately day 8. This study on a medium of 8 days after their admission to the hospital. And in fact, we did a glucagon stimulation test on those patients after getting a consent from their next of kin, and to assess growth hormone and ACTH reserves. And we detected about 18% blunted response to blunted growth hormone response to glucagon. 16% of those patients had blunted cortisol response to glucagon, and some of those, in fact, had very low morning cortisol. There's some of these patients had a morning cortisol of less than 100, so they were very clearly, very severely cortisol deficient, 100 nanomole per liter, that is. As you might expect, they were very sick, so 80% of them have, in fact, low testosterone or estradiol level. The majority were clearly men. Only 1 had TSH deficiency or low free T4 with a low TSH, and half of them had high prolactin. And I'm not going to talk too much about the posterior pituitary because this is for another talk, but 40% had some melatonin, salt, and water balance between DI or SIDH. So what happened to them over time? Sorry, I don't have an arrow. So this is the growth hormone response to glucagon. So in the green lines are the patient who had blunted response early on. in the acute phase. And as you can see, at 6 months and 12, we studied them at 6 months and 12 months, many of them have recovered, leaving only 3 patients, 3 out of 9, with persistent severe growth hormone deficiency. If you look at the red line, there were 2 patients with the red dots who had a normal growth hormone response in the acute phase, who later on became deficient. And a similar pattern was observed with cortisol. This cortisol response to glucagon. The green lines are the early deficiencies or the early blunted response, and you can see 8 of them had blunted response at 8 out of 50, so that's 16%. And over time, some of them have recovered, leaving 4 with persistent deficiency. But there were 5 patients, in fact, as you can see, this is the red lines, 5 patients who had a normal cortisol response to glucagon early on, who later on became deficient. So we've noticed that nobody really developed new abnormalities after 6 months. So there are some people who developed new abnormalities between 0 and 6 months. This is the time we studied them, but there was nobody who had any new abnormalities detected after 6 months, although some of the abnormalities continue to recover beyond 6 months, although the majority recovered by 6 months. If you look at the other endocrine abnormalities, the gonadotrophin deficiencies, which were mainly testosterone, really, because the majority of these were men, young men with a road traffic accident, as you would expect. And the majority of the testosterone has recovered by 12 months, leaving us a couple of, only a few patients, 3 or 4 patients with or 6 patients really with some deficiency. TSH deficiency was very uncommon, only 1 patient out of 50. And the prolactin, it also recovered by 12 months. The prolactin clearly is a stress response. You'd expect it that the majority of the cases, the prolactin will recover. But still, there was some persistent deficiencies even after 12 months. Now, what about the risk factors for hypopituitarism? Individual studies really did not, most of them did not show an association between the Glasgow Coma Scale scores and the risk of hypopituitarism, but the majority of the patients studied had significant head trauma. However, in the JAMA paper that I showed you before, we found that people with more severe TBI had a higher rate compared to people with moderate or mild TBI. Although the data on mild TBI really has to be interpreted with a lot of caution, because most of these the numbers were small and the patients really did not have a sort of a robust confirmation of the abnormalities. So the data on severe or moderate TBI is more reliable. In studies that looked at tried to correlate hypopituitarism with CT scan appearance, they found that diffuse axonal injury, basal skull fracture, and increased ICP, that's intracranial pressure, have been reported to be associated with an increased risk of TBI. And in the group from Turkey, Fahrettin Kilistimar group showed that there is a possible association with autoimmunity, that those patients with hypopituitarism had a higher titer of anti-pituitary antibodies. So there may be an autoimmune dimension to this. So just to summarize the talk so far, I think there is a persuasive evidence that pituitary dysfunction is common in survivors of TBI, particularly those with severe or moderate TBI, with maybe 25% of patients have some degree of hypopituitarism. Anterior hypopituitarism is probably associated with more severe head trauma, particularly if you look at CT appearance, CT scan appearance, and that pituitary dysfunction occurs early after TBI. It is transient in some cases and recovers subsequently. Conversely, late abnormalities may become detectable in the post-acute phase. Although in our data, we did not really show any new abnormalities after 6 months. Having said that, the Turkish group have shown some abnormalities that sometimes developed after 6 months or after a year, although these results are difficult to interpret in a context of dynamic tests, which has limited or has other than perfect reproducibility. Of course, the question here to me as a clinician here is that this is not just about numbers. So does post-traumatic hypopituitarism have a significant impact on the morbidity, the mortality, and the recovery of patients after TBI? Because that's really the key question here. Is this associated with harm, or are we just reporting numbers here? And in our group, this is the study by Hannon, Mark Hannon in our unit, and he looked at this is a separate cohort of patients, 100 patients who were studied subsequently with severe or moderate TBI. They were predominantly ICU patients, and he measured their cortisol for 10 days, from day 0, day 1 to day 10. And he looked at the cortisol values, and he divided those cortisol values into two groups. One is the patient who have a lowish cortisol. In other words, below the first quartile of range, which was 276 nanomole per liter in this study, and the patient who had their cortisol values between the second, the third, or the fourth quartile. So the one with the lowest cortisol versus the one with the higher cortisol levels. And if you look at the left-hand side of this, so there was 8 out of 21, 8 plus 13 is 21, so 8 out of 21 with lowest cortisol died compared to 9 out of 61 who had higher or healthier cortisol values. So there was clearly those patients with a low cortisol or lowish cortisol had a higher mortality. Now he controlled in this situation for the severity of the trauma, he controlled for medications and other factors, and despite that, the signal was there. Low cortisol is associated with higher mortality in those patients. There are other studies that looked at the need for inotrope support in those patients, blood pressure measurement, and other factors, and they found that those with low cortisol had lower blood pressure, required more inotrope support. So there is, I think, significant, there is a convincing evidence that those patients, some of them do develop low cortisol, and that may be associated with worse outcome. What about quality of life? This is a study from Denmark, from Marianne Klosa and her colleagues, and they look at those patients. Those are the patients who had chronic growth hormone deficiency. They were not acute patients. They were studied many months after the head trauma, and they had severe growth hormone deficiency. And she looked at their quality of life using the Nottingham Healthy Profile. So this looks at different domains, and the higher the score, the worse your quality of life. So the black bars are the ones who had head trauma and hypopituitarism. The gray bars are the ones who had head trauma with a similar severity, but normal pituitary function. And you can see in all these domains, if you have hypopituitarism after head trauma, your quality of life is worse. And clearly, both groups, whether you have normal pituitary function or hypopituitarism, your quality of life is worse than the background population. But this study has shown clearly that the quality of life is diminished if you develop hypopituitarism, both head trauma, untreated hypopituitarism, that is. This is a study from Texas in the US, looking at oxygen consumption after treadmill test. So this is a marker of exercise capacity, measuring the VO2 max here, and patient with GHS is growth hormone sufficiency. Those with normal growth hormone response compared with growth hormone insufficiency, i.e. partial growth hormone deficiency, or growth hormone deficiency, i.e. a more severe growth hormone deficiency. So those ones, growth hormone deficiency or insufficiency, had reduced exercise tolerance, exercise capacity compared to those with a normal growth hormone response. Another indicator that those patients are paying a price for having hypopituitarism. And the question that follows from this is, does hormone replacement, now clearly, testosterone deficiency, cortisol deficiency, all this has to be replaced here. You can't do randomized studies on these because they have proven benefit. But in terms of growth hormone replacement, does growth hormone replacement in those patients who have growth hormone deficiency, does it improve recovery, rehabilitation, and quality of life? There hasn't been any randomized controlled study, so we don't have the full answer to this. What we have is small studies which are uncontrolled and showing some benefit of growth hormone. We looked with the help of Professor John Monson. Some of you may know him. He was my mentor in Barts a long time ago, and he looked at the KIMS database. So the KIMS is, some of you may know it, is a growth hormone database for genotropin, which is the Pfizer growth hormone. So it has more than 10,000 patients, probably higher, more than this number. And they have data on patients who are replaced with genotropin on a background of growth hormone deficiency. And he looked at patients with non-functioning pituitary tumors and patients with TBI, and look at the response to growth hormone in both groups to see if you can compare it. And in men, to a lower score, a drop in score means improvement quality of life. So in men, the response to growth hormone is similar between TBI and FPA. And in women, patient with TBI, in fact, show more of an improvement after growth hormone replacement compared to non-functioning pituitary adenomas. So this data support the notion that growth hormone replacement in those patients is associated with at least a similar benefit, if not more, than you would get in other forms of hypopituitarism. So in the last few minutes, I'm going to talk about screening, who to screen. I think the data is support screening all patients who have moderate or severe TBI. A group from Britain have written a consensus statement, and they advise that patients who spend more than 48 hours in a hospital should be screened. And now clearly the majority, almost everybody with severe or moderate TBI is going to spend more than 48 hours in hospital really. So it's essentially the same thing. Patient with chronic repetitive injuries. So I didn't show you data on this, but boxers, again, the Turkish group looked at patients with boxer, whether it's kickboxing or other form of boxing, and those are the ones who have repetitive head traumas, and they do develop growth hormone deficiency. So perhaps those ones should be screened, particularly professional boxers. And in those with mild TBI, now there's a lot of mild TBIs, it's going to be impossible to screen these patients, but if they showed signs suggestive of hypopituitarism, they perhaps should be screened, so selectively rather than universally. So how do we screen? We believe that it's important that those patients who are in the hospital with severe or moderate TBI should have their cortisol measured in the acute phase, day 1 to day 7. We suggest a cutoff of less than 300 nanomole per liter or 11 microgram per deciliter, or if they have cortisol higher than that but show signs of cortisol deficiency such as hypotension, higher requirement for inotropes, or hyponatremia. So if that's the case, we recommend replacement hydrocortisone. If they don't have these features, the cortisol is higher than 300, then we don't recommend glucocorticoid replacement. And the early phase, really, we don't need to check anything else because there's a lot of changes that occurs during the recovery phase. At 3 to 6 months, we recommend to assess the adrenal, the gonadal, and the thyroid axis, and then treat any deficiencies that are detected. And at least in selected patients, perhaps at 1 year time, we should consider the assessment of growth hormone secretion, particularly for those who showed poor recovery of their after-head trauma. The reason we're waiting for 1 year after growth hormone deficiency is because, as I showed you, some of the abnormalities early on do recover. And a growth hormone replacement is not a straightforward replacement, really. You don't want to replace somebody that maybe 3 months later will recover. So it may be reasonable to wait for 1 year, at least 6 months, but between 6 months and 1 year before you replace growth hormone. So in conclusion, undiagnosed hypopituitarism may have an important contribution to morbidity and even maybe mortality associated with TBI. And TBI patients are at particular risk of glucocorticoid deficiency, particularly those with severe or moderate TBI in the acute phase. So screening for post-traumatic hypopituitarism, in my view, should be part of the routine multidisciplinary care for those patients. In the acute phase, clearly you should screen for adrenal insufficiency. It sometimes can be difficult interpreting cortisol values, but you have to use the clinical judgment. 3 to 6 months, assessment adrenal gonadal and thyroid axis. Adrenal axis, I use a synactin test or a corticotrope or ACTH test. It's a simple test to do and it's reasonably reliable. And at 1 year, consider growth hormone test, at least in some patients. And the observational data suggests beneficial effect of growth hormone replacement in post-traumatic post-traumatic growth hormone deficiency. So I'll stop there, and I thank you very much for your attention. I'll take any questions or comments.
Thank you, Dr. Thank you, Dr. Agha, for the very lucid presentation. And there is a lot of questions on the chat box. So the first question was that how long to follow up these patients for the various pituitary hormone deficiency. So I think you already mentioned you should follow up to at least 1 year. Or
yeah. So we feel that 1 year is the reason. I mean, if you diagnose deficiency, and you start them with treatment, you need to follow them up. But those who are normal at 6 months, you may consider growth hormone test at 1 year. But beyond 1 year, I think if everything is normal, then there's no need to follow them up anymore. Now, I know that the data from Turkey showed that some of them may develop abnormalities after 1 year, but I have to say I'm not too convinced with this. And clearly, you have to put an end to testing at some point because there's a lot of these patients. So you have to be practical about this.
Thank you. Other question is that have you seen any patient with cerebral salt wasting? What is the chances in the TBI patients, cerebral salt wasting?
I have to say, in the study that we did, it was a retrospective study, we had one patient who had features suggestive of cerebral salt wasting, but it's a pretty rare occurrence. So the majority of those patients with hyponatremia really have SIDH. And so cerebral salt wasting is probably quite rare after TBI. It does occur, but the incidence is much lower than SIDH.